Hi everyone, this is going to be our first lecture in the strabismus series this year. It's going to cover an introduction and motor physiology and anatomy. The goal of this lecture is going to be to review the basic strabismus terminology and extraocular muscle anatomy and physiology so that you can participate in strabismus clinics in the ORs. Three specific learning objectives for this session is going to be to list the abbreviations for the horizontal and vertical phorias and tropias, which might be intermittent or constant, at distance and near, recognize incontinent strabismus and the common mechanisms of this, and describe the innervation and the primary, secondary, and tertiary actions of the 6 extraocular muscles. So first of all, when you're in the office looking kids, you have to be interesting and show interest. Have fun toys, talk to them about common TV shows, about what they're wearing, superhero shirts or shoes. Try not to show any fear because they'll pick up on that and not behave for you. Get to the important stuff first, unlike with adults where you can do every step of the exam in order. And kids, you have to try to pick what's going to be the most important thing for that visit and get to it right away. And then don't be the bad guy. If you have to resist or restrain the patient, use it as the last step. Get everything else done first. If you have technicians, have them do the drops so the kids won't hold it against you. So here's some examples of just the toys we have in the office. Have something fun in your pocket or on the desk to play with the kids. So terminology, there's lots of different ways to describe strabismus. One of the basic ones is bifusional state, which can either be a phoria or a tropia. So phoria is a deviation of the eyes when fusion is suspended, covering up an eye, the eye drifts. When fusion is regained, they bring the eyes together. So it's a little held latent by fusion. A tropia is a manifest deviation of the eyes when both eyes are open. So if a patient sees the eyes drifting, the parents knows the eyes drifting at home, that's by definition a tropia because the eyes are drifting sometime when fusion should be in place. Tropias can be intermittent or constant. So let's take these two pictures on the right-hand side here. The top picture is a patient that has straight eyes. Bottom is the same patient with the eyes deviated. So this can either be a patient who has a phoria in the bottom picture, the coverage is taken away, and then he regains fusion like the top picture. It could be a patient who's got an intermittent tropia with good control on the top and then drifting in the bottom. Or we just had that bottom picture, it could be a constant tropia. The second way we can use terminology to help us with strabismus is by direction deviation. So a patient can have a pseudo deviation, which is the top picture here. The eyes appear like they're crossing, but they're truly straight. If you see the corner reflex, they're similarly placed in both eyes. The middle picture is an esodiviation. It's a convergent deviation of the visual axes. The eyes are crossing in. And the bottom picture is an exodeviation, which is a divergent deviation of the visual axes. The eyes turn out. Again, these can be phorias or tropias, constant or intermittent. You can also have vertical deviations, which is either hypertropia or hypotropia, which is a vertical deviation of the visual axes. I usually designate the higher eye, so it's the right hypertropia. It's the same as the left hypotropia, but in my charts will usually be designated a right hypertropia. Cyclodeviations can occur as well, where the visual axis is twisted upon its anteroposterior segment. A third type of strabismus terminology is whether deviation is commentant or incontinent. Concomitant means the deviation is similar in all fields of gaze as well as distance or near. An incontinent deviation is a deviation that varies in field of gaze or distance near. So if you look at the top picture here, they have an esotropia that is better in left gaze and worse in right gaze from a 6th nerve palsy. The reason for the deviation is not all that important, just recognize that the deviation is different across the field of gaze. The bottom picture, the patient has an inability to elevate the right eye in adduction especially. This is a right Brown syndrome, so if you see the deviation up in right gaze compared to left gaze, there's an incompetence there. Incompetence is important because it usually implies a paresis of a muscle, a restriction of muscle, or an abnormality in accommodation and convergence. So a number of pretest questions as we go through here. Look at the question, answer in your head. You can pause if you need to and then move on. We'll have the answers towards the end. So here's the abbreviations that we use in the office, and this is pretty common across most strabismus docs. An E, an X, an RH, an LH. Without a T is an esophoria or an exophoria. If you have a T, it becomes a tropia. An ET in parentheses is intermittent, so if the T is in parentheses, it's an intermittent tropia. If there's no parentheses, it's a constant tropia. If you put an apostrophe next to the E or the T, it's a deviation at near. So again, the difference is no T is phoria, T is tropia, parentheses is intermittent tropia, and an apostrophe is deviation at near. Okay, let's move on to anatomy. So the anatomy of the extractor muscles is 3 nerves. They innervate the 6 extractor muscles. The third nerve has 2 divisions. The superior division innervates the levator as well as the superior rectus. The inferior division of the third innervates the inferior rectus, inferior oblique, and medial rectus. The fourth nerve solely innervates the superior oblique, and the sixth nerve solely innervates the lateral rectus. Here's another pretest question. Read through it and pause if you need to, and then move on. So surgically, knowing where the insertion of the muscles is important when you're trying to hook the muscles. There's some variability with these, especially in patients who are very young, but typically they follow what we call the spiral to low, with the medial rectus being closest to the limbus, about 5.5 millimeters back, followed by the inferior rectus, 6.5, lateral rectus about 7, and superior rectus about 7.5 or 8 millimeters back. This is helpful when the muscles haven't been operated on before, or to use them as landmarks if you're trying to reoperate a muscle to figure out where they've been placed. When you're thinking about the secondary and tertiary actions of the muscles, the angle of the vertical and oblique muscles to the visual axis are important. So the vertical recti are set off by about 23 degrees to the visual axis, and the oblique somewhere between 51 and 57 degrees. If you look at the diagram on the bottom on the left, you'll see that in primary gaze, the superior rectus is about 23 degrees off from the optical axis. If the patient were to abduct the eye, move it into a lateral gaze by 23 degrees, you'll see that the muscle plane as well as the visual axis are in the same direction. This makes them also a pure elevator. If the eye was able to adduct 67 degrees in the bottom left picture, the superior rectus then becomes a pure intorter because it's perpendicular to the visual axis. If you look at the bottom right picture, this is looking at the oblique muscles, and specifically this is the inferior oblique, which is somewhere between 51 and 57 degrees depending upon the text with the visual axis. In this case, you can see if the eye is abducted 39 degrees, it becomes a pure torter, meaning it is a pure extorter. And if the eye is able to adduct to 51 degrees, then inferior oblique becomes a pure elevator. So just it'll show you the relative actions of muscles in adduction versus adduction for the vertical rectus and the oblique muscles. One other important surgical relationship is the relationship between the oblique muscles and their corresponding rectus muscles. So superior oblique runs between the superior rectus and the globe, so it's inferior to the superior rectus. And the inferior oblique runs between the inferior rectus and the floor, so again it is inferior anatomically to the inferior rectus. So when you're hooking the inferior oblique or the superior oblique, you need to know the relationship between that and the vertical rectus muscle. One last important anatomical relationship is the relationship between the inferior rectus and the lower lid retractors. So the lower retractors arise from the sheaths of the inferior rectus and the inferior oblique, which is called Lockwood's ligament. If you end up recessing the inferior rectus, the lower lid will follow that back and can cause lower lid retraction unless you separate the lower lid retractors from the inferior rectus belly. Okay, here's a question about the vascular supply to the anterior segment. Take a look at it and come up with a good answer. Okay, so the vascular supply of the muscles is important because the anterior segment, the cornea, the iris, the lens, has its blood supply from the anterior ciliary vessels. Each rectus muscle, the superior rectus, inferior rectus, and medial rectus, has 2 anterior ciliary arteries. The lateral rectus typically only has 1, but this can be variable. The vortex veins, when you're operating surgically, are to the sides of the superior rectus and inferior rectus, probably about 10 to 12 millimeters back. So don't hook really deeply because you might hook the vortex veins, and they tend to bleed a lot. Okay, so this gets somewhat complicated, and we're going to get through this slowly, and we'll have time to discuss it in the lecture as well. Each muscle has a primary action, so the medial and lateral rectus are for adduction and abduction. The vertical rectus and the obliques also have secondary and tertiary actions, and these allow the globe to rotate around the 3 axes. So the x-axis here, if you rotate around the side-to-side axis, elevates and depresses the eyes. The z-axis goes up and down, it creates adduction and abduction, and the y-axis, which is front to back, creates torsion if you rotate around that axis. Here's a quiz question, look at it and answer it. This is a busy but important chart that's in your book. Try to have it memorized. the shorthand for this is the mnemonic SYN and RAD. The superior muscles intort the eye as their tertiary secondary action. So superior oblique, superior rectus are both intorters. Conversely, the inferior muscles are extorters. The inferior rectus, inferior oblique are both extorters. The recti, the superior rectus, inferior rectus, their tertiary secondary actions are to adduct. Conversely, the oblique muscles are abductors. So that's the short way to memorize all the secondary and tertiary actions of vertical obliques. Okay, when we describe eye movements, we can have abductions, which is just a monocular movement of the eye, cover up one eye and see what the other eye is doing. Versions are conjugate bilateral movements in the same direction. So the top picture here is levo version, the eyes are both moving to the left. And then divergences are disjugate binocular movements, which is convergence or divergence, which you see in the bottom picture here. Agonists describe two muscles in the same eye that have the same action. So superior rectus and the right superior rectus and right inferior oblique both elevate the eye. The left inferior rectus and left inferior oblique both extort the eye, so two muscles in the same eye that have the same action. Antagonists are two muscles in the same eye that have opposite action. So the medial rectus and the lateral rectus oppose each other in abduction and adduction. This is Dr. Sherrington. He had his law of reciprocal innervation, and it concerns antagonists. So an increase in innervation of contraction of one muscle is accompanied by a reciprocal decrease in innervation and contraction of its antagonist. So when we look to the right lateral rectus increases its innervation, the right medial rectus decreases its innervation. Duane's is a co-contraction syndrome that you'll learn more about in further lectures, but it violates Sherrington's law because the medial rectus and the lateral rectus fire at the same time, and it causes retraction of the globe. Here's a quiz question, answer it. Yoke muscles are two muscles in opposite eyes that move the eyes into one of the cardinal positions. So right medial rectus and the left lateral rectus both move the eye into left gaze. The right superior rectus and left inferior oblique both move the eye up and right. Left inferior rectus and right superior oblique both move the eye down and left. So those are yoke muscles. Here's Dr. Harrington, his law of modal correspondence in concern of yoke muscles. And it says that equal and simultaneous innervation goes to yoke muscles that move the eyes into a certain position. So DVD is a situation that violates Hering's law. If you look at this picture, the center picture has the left eye going up, and then it comes down to retake up fixation with the left eye depressing. The right eye should also depress. It doesn't happen with DVD, so it disobeys Hering's law. So to finish up here, just some high yield facts. Innervation, the superior division of the third does the levator and superior rectus. Inferior division of the third does the inferior rectus, inferior oblique, and medial rectus. The insertions are listed here, how far they are from the limbus. The superior oblique runs between the superior rectus and the globe, and the inferior oblique runs between the floor and the inferior rectus. So the oblique muscles are both anatomically inferior to the rectus muscles. The arterial supply, each rectus has two anterior ciliary vessels except for lateral, which has one. And then a good mnemonic is SYN and RAD, where the superior is intort and the recti adduct to get to the secondary and tertiary actions of the muscles. Sherrington's law concerns antagonists. Hering's law concerns yoke muscles. And here's the post-text and the questions. Which muscle insertion is usually nearest the limbus? That's the medial rectus. Which is correct interpretation? Let's see. D is ET apostrophe esotropy at near. Anterior ischemia is most likely in which of the following situations? C is the diabetic patient with three muscles off of one eye, and which is incorrect. This one is C, the inferior oblique in towards the eye. That's incorrect. The inferior oblique extorts the eye. And that's our lecture for the day. Look over it. If you have any questions, send them to me. Thanks.